Hello, everyone. Welcome to the College of Licensed Practical Nurses of Newfoundland and Labrador and the College of Registered Nurses of Newfoundland and Labrador's webinar on medical assistance in dying, MAiD. For today's presentation, we ask that you hold your questions until the end. At that time, you can unmute yourself or type your question in the chat box. Both of those functions, the unmute and the chat, are located at the bottom of your screen. Today's presentation will also be recorded. However, we will stop the recording once the presenter has finished, so before the question and answers. Originally in the past, we discussed Bill C-14, and with the changes to the Criminal Code Bill C-7, it is only appropriate to discuss this with the nurses of Newfoundland and Labrador. So today we have two special guests with us, and I will introduce the first one, and then I will ask her to introduce our second one. So we have with us Debbie Squires. So Debbie is a registered nurse, master's prepared, with many years of nursing experience working in various roles in many healthcare settings within Eastern Health. For example, pediatrics as a frontline nurse, community health nurse, instructor with the Center of Nursing Studies in the Bachelor of Nursing program, clinical nurse specialist for the palliative care in the long-term care program, and currently as professional practice consultant for nursing. Debbie was seconded as Medical Assistance in Dying, MAiD lead, from 2016 to 2018. And Debbie's current portfolio includes medical assistance in dying. So welcome, Debbie.
Thank you so much. Thank you very much for inviting us here today to present for the colleges. And it's my pleasure today to introduce Dr. Aaron McKim. So a lot of people online may very well know Dr. McKim. He is a family physician. He's also certified in care of the elderly. Dr. McKim is a native Newfoundlander, graduating Memorial Medical School in 1998. Having worked in Nova Scotia, the Yukon, and British Columbia, Aaron and his wife, who's also a family physician, moved back to Newfoundland in 2002. He has been working in private practice, and for the past 19 years has been working with Eastern Health in the long-term care program. He was also clinical chief of the long-term care program as well from 2012 to 2017. He's also certified as a palliative care instructor with Pallium Canada. And Dr. McKim has traveled throughout Eastern Health, or Eastern Newfoundland actually, teaching end-of-life care to community care teams and long-term care teams through the accredited Learning Essential Approaches, or LEAP training, through their program. Dr. McKim has taken a lead role in Eastern Health with advancing accessibility to assisted dying. He's been one of the main organizers of several accredited multidisciplinary programs teaching medical assistance in dying to healthcare professionals. And he has been working for several years helping to set up the provincial medical assistance in dying infrastructure, including 2 years with the province of Department of Health and Community Services as the provincial coordinator of medical assistance in dying. And recently as Eastern Health Region Health Authority, or in the Eastern Health Regional Health Authority, as the regional medical director for medical assistance in dying. He's also a faculty member at Memorial University Medical School and has been a unicyclist and juggling instructor for the St. John's Juggling Club for the past 30 years. And if anybody online has attended our LEAP sessions, you would have been witness to some of that, some unicycling and some juggling. Quite talent he has there. Dr. McKim lives with his wife and their 3 children and their 2 dogs and their family farm in St. Philip's, Newfoundland. Welcome, Dr. McKim.
Thank you very much, Debbie. That was lovely. So Debbie and I have been teammates, I guess, in teaching palliative and end-of-life care throughout the Eastern region. And it's been really quite gratifying being able to get out and see people face to face and work with them and see the diversity and the breadth of skill that is across this region. So thanks everybody for attending today. I'm going to do my best to outline both to review the criteria for medical assistance in dying, and then to talk about some of the recent changes that happened earlier this year that have expanded eligibility to some degree. So this is an area that's a little bit out of some people's comfort zone, but it's actually been part of the law now since 2015 is actually when they rescinded the old law. So it's been 5 or 6 years. So it's really not that new anymore. So, but there's still a fair bit of discomfort around it. So mostly it's fairly straightforward. So hopefully today people will be able to get a little bit of a better understanding. Now, I don't know if I can advance this here. For some reason, there we go. Okay. So we're going to recap the numbers in Newfoundland just to talk about, what number of cases we've had and how that compares with the rest of Canada. Look at a few key resources and then review the eligibility criteria, look at the amendments that have come, and I'll just do a sort of a brief summary. Some of the slides go into a bit of detail, but that's really if you want to sort of get a more comprehensive understanding of some of the nuances. But the broad strokes are sort of on headers right at the top of the slide, so you don't have to look at the whole entire thing right away. We'll talk about a few of the current ethical challenges that are coming down the pipe with these cases, and look at review process and final message. So the average age across Canada for people who request MAiD is about 75. They find as age increases beyond that, there are fewer and fewer people who are eligible because of advancing dementia. Currently, MAiD accounts for about 2% of all deaths across Canada, but it's about 1% in Newfoundland, although the federal statistics don't quite reflect that. The most common cause are underlying medical condition for people requesting MAiD. The majority, about 55%, is cancer, followed by neurodegenerative, which is about 25%. So that would be ALS and Parkinson's and that type of thing. And then around 10 to 15% of people have some kind of organ failure, whether it's COPD or congestive heart failure or renal failure. And then probably about 5 to 7% are other causes. All right, so if you look at who mainly is providing medical assistance in dying across Canada, about 2/3 of the providers are family medicine physicians. You'll see the nurse practitioners account for a fairly substantial chunk. About 7.1% of MAiD providers are nurse practitioners, and followed by palliative medicine and a few others. You can see that there, oncology is there, psychiatry is there, critical care and emergency medicine. So there's a lot of different fields. It doesn't belong to any one particular field, and as such, it's really everybody's responsibility. One of the concerns was, are people choosing medical assistance in dying because they don't have good access to palliative care? Well, they looked at that. So in 2019, they looked at all the requests, and of the requests, 73.5% had access to, actually, sorry, this is a different slide. This is eligible versus withdrawn. So of all the requests, the majority of people did have MAiD. About a little over 25% of the people who requested did not have MAiD. And of those people, probably the majority of them, 15 of the 26.5% died before MAiD could occur. And a small percent withdrew, and a very small percent were ineligible as well. Palliative care was accessible to the vast majority of people who requested MAiD. So 82% of people who had MAiD had received palliative care. And of the ones that didn't receive palliative care, almost 90% of them were able to access palliative care, but chose not to. So it's accessible in the vast majority of people. This is just a pictorial representation across Canada. You can see the bars on the bottom. On the far left, that's the rate in BC, and on the far right, that's the rate in Newfoundland. We're lower than the next two lowest provinces. So there's a much lower rate of medical assistance in dying in this province. And there's no way of knowing exactly why that is, but we've speculated on some of it. In 2019, you can see this is a statistical breakdown. 3.3% of the deaths in BC were because of MAiD, and about 0.3% in Newfoundland. It's actually come up to a bit closer to 1% now, but as you can see, all the rest of the provinces are higher than that, except Saskatoon is 1% as well. So why is it so low in the province? Well, it's just a matter of speculation. So the first, question was, is it because of availability of assessment and provision? Are there enough providers? Are there the resource to assess people? And but by far and away, I think I can say confidently that we can pretty well always find somebody to do an assessment. Occasionally, we've had to resort to doing assessments by video, but usually we can get at least one of the assessors in person, and preferably one of the assessors actually knows the patient. So we usually try to get, either the family doctor or the nurse practitioner who's involved, whoever the primary care physician, or in some cases, the neurologist or the oncologist who knows the patient will agree to be involved as an assessor. Occasionally, nobody connected to the patient wants to be an assessor, and so we have to go outside of that group. And we've been able to find people to do that pretty well all the time. We've had one or two cases where the patient, requested MAiD kind of at the last minute and then precipitously declined and went downhill and died within, a day or two. In those cases, we just didn't have enough time to get an assessor in. I think there's a lot of people who don't know that it's an option. So access to the information and to the connections to get the ball started, I think, are lacking in some places. And that's a matter of the general public's education, but also, I think, to a large degree, we as healthcare professionals need to take some responsibility there, that we need to be sure to have these discussions with patients early on in the process so that they can properly consider all of their options. There may be some degree of religious influence on this. There's, a lot of Catholics in Newfoundland, and some Catholics and some other religions believe that nobody should have MAiD, that it's not okay. So, people have that opinion. They're entitled to it. But I think everybody has the right to make up their own mind about this. There's a question, was there, because of palliative care, was there not enough access to palliative care? Usually in countries that have excellent palliative care are the countries that have the most accessibility to medical assistance in dying as well. There was initially a fear that, that MAiD would be brought up instead of palliative care, that people would be sort of pushed down the MAiD pathway rather than getting good palliative care. But really, it's not a competition. Now, one thing I did find surprising is that about 90% I've heard of the palliative care physicians and palliative care units across the country are adverse to MAiD, are not supportive of MAiD, which I found very surprising. But I also have found that it tends to be the older, established palliative care practitioners who are the least comfortable with it, for the most part, and that the people who are newer to the field tend to be more comprehensive and inclusive in their options and ideas. And so I think it's important to go through this piece of it, particularly for the nursing community. It's my understanding that it's still written in your clinical practice guidelines that you shouldn't bring up medical assistance in dying unless the patient specifically asks you about MAiD. And this doesn't really make sense to me, because if a patient doesn't know about it, how can they specifically ask about it? I mean, it would be ludicrous to put those kind of restrictions on, say, somebody had an unwanted pregnancy, but you weren't allowed to stop to talk about abortion unless the patient mentioned the word abortion. That would never happen nowadays. It doesn't make sense. And I think it's similar with medical assistance in dying. I mean, a person can't make an informed decision if they don't know about all their options. So this is a position statement from the Canadian Association of MAiD Assessors and Providers. And I'll just read it. I think it bears emphasizing. There is no provision in the law that prohibits healthcare professionals from initiating a discussion about MAiD or responding to questions about MAiD from a patient. In fact, it specifically says in the Criminal Code of Canada that any practitioner can talk about the legal provision of MAiD without being worried about any kind of reprisal from a legal standpoint. All healthcare professionals have a professional obligation to respond to questions about MAiD from patients. It does go on to elaborate, only physicians and nurse practitioners, jointly referred to as clinicians, involved in care planning and consent processes have a professional obligation to initiate a discussion about MAiD if a patient might be eligible for MAiD. So they go further, saying not only can you talk about it, but you have a professional obligation to talk about it if you're a nurse practitioner. The discussion should include all treatment options, including palliative care and the option of MAiD. And the appropriate timing of initiating a discussion about MAiD is determined by the clinical context. Healthcare professionals must not discuss MAiD with a patient with the aim of inducing, persuading, or convincing the patient to request MAiD. In other words, you can't push your agenda on them. You can't say you should have MAiD, but you totally can say MAiD is one of the options available to you, and do you know about it? And do you want to have more information about this? We'll talk a little bit more about that in a minute. So these are the Newfoundland numbers by region. This is only up to 2019. I don't have the numbers for the rest of the province for 2020 yet. But you can see, you know, Lab Grenville, which is the least populous part of our province, has the lowest number, and followed by Western, which has the next, and then Central, which has more, and then Eastern, which has more in terms of population. So the numbers of MAiD requests directly reflects the population in each region, but by far and away, Eastern Health has had the vast majority of them. Now, this is up to 2019, the end of 2019. Now, this is the stats for Eastern Health, and you can see that that our numbers are you know, progressing a fair bit. I mean, 2020 was the highest year at 45 requests, and 2021 so far we're about, you know, just over 6 months into it, and we've had 24 requests. So we're actually looking to surpass. It looks like it's going to surpass last year's. So it tends to go up every year, and this is reflected in the Canadian statistics across Canada as well. You'll notice here I've got two columns. I've got MAiD requests and MAiD provisions. There's a tendency to talk about MAiD deaths. In other words, people who requested MAiD and then went ahead and had MAiD. But you know, I'd remind you that there's a lot more work to it and a lot more to it than just the provision. And the way I sort of see it is that this is a person's right to choose. They have the right to have this choice. And whether they choose to have MAiD or they don't choose to have MAiD, in some ways is beside the point. It's their right to have that choice. And as a MAiD, I guess, advocate, I'm advocating for people to have the right to have the choice. I'm not advocating for people to have MAiD. Whether they have it or they don't have it, I have no agenda one way or the other. It's really to support somebody's right to have that choice. And whether they have it or they don't, even if they never have MAiD, when people are approaching the end of life, often there's a lot of chaos. There's a lot of things out of their control. And you know, their health is out of their control. Often where they reside, their residence is out of their control. Their finances often are you know, spiraling out of control. So much is out of control. And if somebody feels that they have just a little bit of control, that they can choose where, when, and how they're going to exit, that gives people a sense of self-determination. It gives them a therapeutic benefit often. And whether they go ahead with it or they don't, the sense that if things get so bad, they have an out, they have an option if they so choose, I think helps people to be less afraid. I think often at end of life, people are more afraid of suffering than they are of dying. And this helps alleviate some of that fear. Having the knowledge that if it gets too bad, you have a plan B, that you can have the injection and you can end your suffering if you so choose. I think that helps people to withstand that part of their life a little bit better and with a little bit more courage. So you can see, you know, on the right-hand column, we have the sort of, we get into the details of the people who didn't have MAiD, you know, how many of them just chose not to and died naturally. That's what I mean. Some people died so quickly or so precipitously that we didn't have a chance to complete the evaluation. And those are the numbers that I really want to keep track of, because that's where, you know, if we have the system set up properly, some of those numbers can be avoided. And then people who withdrew or were not eligible or lost capacity are recorded there as well. So we kind of get into the details of, you know, people could have MAiD if they wanted it. If they chose not to, that's fine. But the ones who wanted it but weren't able to have it, those are the ones where, you know, we want to try to do better. But fortunately, those numbers are not very high. Okay, so cases versus provisions. I mean, for every person who has MAiD, they've had 2 assessments. They've gone through an entire process. Sometimes there's much more to it than that. There's, you know, doubling down on what other treatment options do they have? Have they optimized their palliative care and their treatment of their pain and suffering? So there's a lot of work that goes into it. And if in the end the person chooses not to have MAiD, which is fine, then they don't get counted in the statistics as a MAiD case. When in fact, if we want to look at the workload involved and the amount of resource we need to allocate in terms of planning for this, you really need to look at assessments, not just provisions. Yeah, in Newfoundland, about 55% of eligible cases have MAiD. Other regions, it's higher. Some places have more vetting before they actually send in the application for it. So a higher proportion of the people who apply actually go ahead to have it, because the ones who didn't want to have it have already been weeded out. Um, I'd say about half of the cases, roughly, people want it as what we call a back pocket eligibility. In other words, they want the option, but they don't want to go through with it, at least not at the moment. And about half of the cases, people have been thinking about it, talking about it. They want to have it as soon as possible. They are done. They are suffering in the worst kind of way, and they want to have MAiD as soon as possible. So there's a few resources if you need more information about this. Some of this is now no longer relevant, but we'll talk about that. So the first thing I did when I was asked to be part of the MAiD planning in the Department of Health was to try to make a document that would answer people's questions. So if somebody wanted to know more about MAiD, but hadn't yet made up their mind, they just wanted to know what was this option all about, I wanted some information available so people could understand the process, the eligibility criteria. And this was mainly for both patients and for healthcare practitioners who wanted to sort of get the basic ropes of it. So at first, when you type in, if you go to Google and you type in MAiD NL, at first we would get motivated maids and MAiD to clean and Molly Maid services. But now if you type it in, the first hit you get most of the time, I think, is medical assistance in dying. And this is a frequently asked questions document in the Department of Health and Community Services. Now, last time I checked, which was yesterday, this had not yet been updated with the C7 amendments. And we're trying to kind of, remind them that they need to go back and update some of this information. So I would warn you, if you go to this document, it is not complete. In other words, some people who might not be eligible according to the criteria on this document might still be eligible under the new amendments. And we'll talk about those new amendments in a bit more detail. How am I good for time? Okay, so we're getting there. So we had feedback that the first document we'd had, this was the first version of it. You see, it's got the sort of color splotches on it. Sort of the graphics artist put some decorative stuff on it, and the pictures are fairly somber. They're largely the imagery is of a person kind of looking into the light or looking down the path. And we had the feedback from people we talked to that this was kind of lonely and a bit depressing. So we did a version 2 where, number one, those colored splotches were messing up screen readers for people who had visual impairments. So even if you're pretty well completely visually impaired, you can still get computers for your programs for your computer that allow you to read stuff and to look at pictures in a descriptive text. But having those color splotches can mess up those programs. They don't know if it's a picture or if it's just weird stylized text. And you need to have the proper contrast between pictures and letters and the background so that they can pick out where stuff is. So we went back and sort of vetted it from a graphics point of view, so a screen reader could look at it. So this was accessible to people with visual impairments. We also did a sign language version of it and an audio version of it for people who were visually impaired. And we asked them to put some graphics on it that were a little bit less depressing as well. So you can see in the version 2, they maybe went a little overboard on the other direction. But it does reflect the reality in some of the MAiD cases that, as well as tears, there's often laughter as well. There's all of the human context in there. And often people have a celebration of their life lived, as well as the sadness of it coming to an end. And sometimes it is a party. And sometimes people are quite jovial and full of joy as well for the life that has been lived. So there is that part of it as well. It's not just all tears, although they're often a part of it as well. This was a course that we spent a fair bit of time and effort building online. And for the past year, it's been an accredited online education course, mainly directed at MAiD providers or assessors. But as of June, the accreditation has lapsed on this. And despite my requests, the Department of Health has not said anything about funding a new one. Although I have just had word that the National Organization of Canadian Assessors, the Canadian Association of MAiD Assessors and Providers, are looking at putting up a sort of a national education module for people to use. So that might help alleviate it. But I really think that we should have our own, until that national education thing is up, we really should have our own provincial education process on this, because not everybody can access a MAiD provider close at hand to help them with their first assessment or provision. There is a really good document some of you might want to download, and you can even give it to patients. And we have updated it with the new C7 amendments. If you go to the Eastern Health intranet and ask for and search for end of life options document, you should get this document. And it basically talks about all of the options that you might want to think about at end of life. So it talks about advanced care planning to start with, and how to get more information about that. And there's a few websites of where to get the kit for advanced care planning. It also talks about palliative care. It talks about medical assistance in dying. Also, there's some information on organ donation and grief and bereavement services that are available. So all of the things that people might want to, that the patient and the families might want to think about and discuss. And so hopefully this will make people a little bit less nervous about talking about all of the options, including MAiD, because if you outline all the options, nobody's going to be able to come back and say, well, you were trying to push this one option more than the rest. No, you got a document that's talking about all of them. And if the patient wants to get more information, then they can, or they can ask about it, or they can talk to you with it. So this might help people, because I know there have been some instances where nurses thought that the patient should know about it, but didn't feel comfortable themselves to initiate a discussion because of the way that the clinical practice guidelines are written for the College of Nurses. So this is something that can hopefully help with that. If all else fails, you can call your local regional MAiD coordination group. So these are the numbers for all the different 4 regions. You can telephone, you can email, you can fax, even if you just want to know more information or how to get more information or how to get the ball rolling in terms of getting the assessment process started. So, and that's readily available on the MAiD document, on the frequently asked questions document as well. There's also some stuff on the Eastern Health intranet, and I believe that the other regions have similar types of resources online. So if you go to programs and services on the homepage for the intranet here, and then you click on the orange tab, committees and initiatives, medical assistance in dying is there. I think now it's actually gone up to the top of the middle column, so you can get all the forms and all the information that you need there as well. There's also the requirement for federal reporting. If you do MAiD provision, or if you get a request for a MAiD provision, even if you don't go, even if the person never actually has MAiD, there's a professional obligation to report this to the federal portal. And if you don't, there's actually laws and penalties that you can incur, up to 2 years in prison if you purposefully do not report it. Although they don't want to use it, they don't want to have to do that to enforce it, but they just want to make sure people report it so that they can get accurate numbers of what's going on. So there's links on the intranet of how to get to the federal reporting thing if you ever get a MAiD request. So the new eligibility criteria. Now this is sort of the central piece of it that I want people to take away. And this is actually lifted directly from the Health Canada website. So you can go online and get this information on the federal website. So just a brief summary. The main elements of this legislation that were new over and above the previous law around MAiD was one was about the eligibility criteria. So probably the biggest change is the removal of the criteria of a reasonably foreseeable natural death. That's what an RFND is there. So reasonably foreseeable natural death wasn't an imminent death. Before C7 was passed on March 16th, a reasonably foreseeable natural death was basically that, their death, you could see that they were going downhill and they were going to die. Not necessarily in the next couple of weeks. It could be up to 5 years in some cases, but that you could see this person had a life-limiting diagnosis or their trajectory was going downhill, so that there was a statistical likelihood that they were going to die in less than 5 years. And if you could show that with statistical tables, then you could make the case that this person had a reasonably foreseeable death. If they didn't have a reasonably foreseeable death, then they weren't eligible for MAiD under the previous legislation. And what was happening is some people who had really bad neurodegenerative conditions, for example, who were suffering terribly, but were probably going to live for another 20 years, so they didn't meet the criteria for MAiD, what they were forced to do was to either take matters into their own hand and commit suicide, which is not illegal, or they would sometimes starve themselves and restrict fluids and food to the point where they were starving to death, and they would become bedbound and start to go into early organ failure to the point where their death was reasonably foreseeable, and then they would be eligible for MAiD, which is an incredibly horrendous thing to have to go through. If you just think about it, somebody who has food and water right there in front of them, but restricts it, and it goes to the point of swishing their mouth out with water and spitting that water out because they want to die so much. And this legislation was changed to allow people like that to access MAiD. So really, they said if you're in an advanced state of irreversible decline, but you don't have a reasonably foreseeable death, you could still be eligible for MAiD. And we'll talk about that in a little more detail. There was a couple of procedural changes. Before, if somebody lost capacity right before MAiD, like say they had metastatic brain cancer, and all of a sudden the Mets pushed them into a delirium, then previously they would no longer be eligible for MAiD because they had to have capacity right to the point before the medications were given to be able to say, yes, I want to have this. Now they've changed the legislation to allow for what they call a waiver of final consent. So if it looks as though there's a chance the person might lose capacity, they can sign a contract beforehand which says, I'm setting the date at such and such a time, and if I lose capacity before that time, you can still go ahead with MAiD because I'm signing this form now. And they can specify whatever conditions they want to around that. So that allows people not to have to go earlier than they would like to for fear of losing capacity. There were a couple of easings of a couple of safeguards. You used to have 2 witnesses. Now you only have to have 1. You had to wait 10 days between the request and being able to have MAiD if you had a reasonably foreseeable death. Now they've waived that 10-day wait period, so you can go ahead with it as soon as you can get all the stuff done. They made a couple of changes around the monitoring of MAiD. So the federal reporting, they're looking at a few extra questions to look at things like indigeneity, the ethnic background, to look at degree of disability that the patient has, and that sort of thing. So that's the broad strokes. So just to review here now, this is, if you take one slide away, this is the slide I want you to take away. This is the eligibility criteria for MAiD, okay? So they have to be at least 18 years old. Now, some people are saying if you're 17 and a half and you've got capacity and you can demonstrate, they should be allowed to. That's being, challenged in the courts. So currently it still stands though that you have to be 18 years old or older to access MAiD legally in Canada. You have to have decision-making capacity when you're being assessed with respect to your health. That doesn't mean you have to remember everything you had for breakfast or remember what happened yesterday. It means you have to be able to demonstrate that you understand the choice and the consequences of that choice in the bare bones of it. You have to be eligible for publicly funded healthcare services. So you have to have an MCP card or an OHIP card or whatever. You have to be eligible for public funded healthcare services. And that's to prevent people coming from other countries for medical tourism to access MAiD here from another country that doesn't allow it. You have to make a voluntary request that's not the result of external pressure. You have to give informed consent, meaning you know all your options and the consequence of those options, and you choose this option. Give informed consent to receive MAiD after all the information that you need to make the decision has been provided to you. You have to have a grievous and irremediable medical condition. Now, grievous and irremediable, that's a bit of a nebulous term. So they define that, and there's more definitions than just this available. But you have to have a serious and incurable illness, disease, or disability that causes you an advanced state of irreversible decline in capability. And you have to have enduring physical or psychological suffering caused by the illness, disease, or disability, or by the advanced state of decline in capability that is intolerable to the person, and they cannot be relieved under conditions that they consider acceptable. In other words, they don't have to accept all the treatments. They could say, I don't want to have that one more, chemo session. I've had enough. I'm done, and I don't want any more. You have the right to do that. So you can refuse treatment. You don't have to say, well, we're not going to give you MAiD unless you try that treatment. No, you can't go down that road. So if the patient doesn't want to have any further treatment, that's their right. So yeah, the big change is removing the natural death being reasonably foreseeable. But now if somebody does not have a reasonably foreseeable death, there's a couple of safeguards that they put in there to try to make things a little more safe. So one of the big problems was that if you open it up to a non-reasonably foreseeable natural death, then somebody who just has refractory depression can say, well, I'm suffering. I've tried all the treatments. I want to have MAiD. So there was some debate whether they should or whether they shouldn't. They were going to exclude mental illness as the sole underlying condition. But then the Senate felt strongly that that would not stand up to a constitutional challenge, and that it would just open the gates completely. So what they did was they kind of compromised, and they said, well, for 2 years, we're not going to allow people with mental illness as the sole underlying condition to be eligible for MAiD. But after 2 years, then they will be. So as of March 16th in 2023, people with only refractory mental illness who have an advanced state of irreversible decline could be eligible for MAiD. But until then, you can't just have mental illness as a sole underlying condition. You have to have, you could have a mental illness, but there needs to be some other condition that's contributing to your suffering and irreversible decline. And so they also said that people who don't have a reasonably foreseeable natural death need to have a 90-day waiting period. And that 90-day waiting period is a couple of things. It's one, to make sure the person meets all the criteria. Two, they required somebody without a reasonably foreseeable death to have expert opinion. Originally, they said there had to be a specialist, or an expert had to be one of the assessors. But then they figured there's going to be instances where people are, out in the middle of nowhere. They don't have access to specialists. They don't have access. So they need to be able to provide. Now they change it to, you have to have the opinion. An expert opinion has to be part of the assessment. So you could have two, assessors who are not experts, but they have sought an expert opinion in whatever the condition is that's causing the suffering. We just had a recent case of somebody who, had chronic pain and early MS and some somatoform disorder. And the question was, do they meet the criteria? Is this just a somatoform disorder? And the conclusion we seem to have come to is that the somatoform disorder in and of itself would not meet the criteria, but because they have chronic pain and they have some MS and there's some effects of the MS and big effects of the chronic pain on their suffering and disability, that they don't just have mental illness as the sole underlying diagnosis. So therefore they would meet the criteria. But there needs to be the 90 days wait period. And that's to make sure you've explored all the options, that the person, knows all the things that could be available to them that might alleviate their suffering, that you've got the expert opinion, and that the person has met all the criteria and all the I's are dotted and T's are crossed. Then after 90 days, we can go ahead with that. Yeah, so there's a lot in those slides, but the blue parts are the crux of it. So the two-track approach is the reasonably foreseeable natural death group and the non-reasonably foreseeable natural death group. So the reasonably foreseeable natural death group no longer need the 10-day wait period. They only have to have one witness. That witness on their request can be a paid healthcare provider. They still say you can't be a witness if you're going to be a beneficiary under that person's death. So in other words, there could be a secondary agenda to pushing them into MAiD. And you can't be a witness if you're an unpaid caregiver, because there can be all these sort of emotional baggage things going on with that, which could bias somebody. So, but you can, now they change it so that you can if you're a paid caregiver. So if you're a person's nurse or an LPN and you're directly caring for this person, you can still be a witness for them. Before you weren't able, but now you can. So that affects you guys. The safeguards, we talked a bit about those. One independent witness. We need 2 independent doctors or 2 nurse practitioners need to sign off and do the MAiD assessment process. The person has to be informed that they can withdraw the request at any time and in any manner. And the person must be given an opportunity to withdraw consent and must expressly confirm their consent immediately before receiving MAiD, unless they've signed a waiver of final consent. Now, if they still have capacity, they still have to do it right before. They still have to say, yes, I want to go ahead with this right before you administer the meds. But if they've lost capacity, they're not restricted from having MAiD because of that loss of capacity, unless they indicate by word or deed at the moment that they don't want to have it. So if somebody's signed an advance waiver or a waiver of advance consent, and you're going to administer the MAiD, and they say, oh, no, don't kill me, then that trumps everything else, right? An utterance or a gesture, a meaningful gesture at the moment outweighs any other pre-existing, word or document. So we talked about final consent, and these are the criteria that you have to specify a date. You have to say, on this date, I'm requesting MAiD. if you don't specify a date, you can't do the waiver, which is a little bit of a dilemma, because if the person hadn't yet specified a date yet, but you're worried they might lose capacity, then should you kind of, encourage them to make a date so they can sign the waiver? Or basically, you tell them the things. If you don't sign a date, you can't sign the waiver. You don't have to sign a date. You don't have to set a date, but then we can do the waiver, and it's up to you. And if they decide to set one and they want to go ahead with the waiver, fine. And if they don't, then that's fine too. Talk about a few of the safeguards, reasonably foreseeable natural death. I'm not going to go through all these details, but the slides are available if any of you want a copy. You can just request and go through it in more detail. These are some timelines of what the feds are looking at doing. They're starting a review process to develop recommendations and protocols. They're looking at regulatory amendments. They're looking at figuring out what should they do about things like emancipated minors, or someone who's under the age of 17 but can still demonstrate that they understand the capacity. Should we allow minors to do this? Looking at other things like advanced requests and mental illness, palliative care, the protection of persons with disabilities, these types of things. These are some additional resources. You can get more information about MAiD, Justice Canada, regulations and monitoring of MAiD. And then this just goes through in table form, what it used to be under C14, and then what the new eligibility criteria are under C7. But I won't go into too much detail about that. Checkboxes. And we've got the forms already underway in terms of having a checkbox available. So if somebody agrees to be a MAiD assessor, we've outlined all of these criteria on forms, so you're not going to miss any of them, and you checkbox on that and have more information available if you need to elaborate on it. But there's a few questions that this brings up. What if somebody has a mental illness and some other relatively minor or intermediate medical condition? Would they be eligible or not? Because it's not technically solely a mental illness as a sole underlying criteria. But I think the way I'm going to look at it, at least until I understand differently, is that whatever is responsible for this patient's suffering, if this patient is suffering because of their mental illness and they happen to have some other medical condition, but it's not really contributing significantly to their suffering, then really their pain and suffering is the mental illness. But if their pain and suffering can be demonstrated to be because of some other issue, then they probably would meet the criteria. So you're not going to exclude somebody just because they happen to have mental illness. But you might exclude them if the mental illness is the reason that they're accessing MAiD. And that's all going to change in 2023 anyway. So people who just have refractory mental illness will possibly meet the criteria then, which is going to be a big step for especially a lot of the psychiatry group in the province, but it's coming. So we're going to have to get used to the idea. One issue that gives me a little bit of unease, I know with people who have high, C-spine paraplegia, people who go from being active, professional sports people to all of a sudden they're wheelchair bound for the rest of their life, often go through a terrible time and a terrible adjustment period where they can't conceive of living with any kind of quality of life under those conditions and want to die. But then after, a period of time, maybe 3 months, maybe 6 months, maybe a year, often will then sort of accept where they are and start to access things like, wheelchairs and computer programs that allow them a greater degree of accessibility, and then go on to become very, happy and fulfilled members of society with those conditions. And so if somebody only has to wait 3 months, then that doesn't really get them past that sort of adjustment disorder period that can sometimes lead to a very happy and productive life. So that's a little bit of a quandary. How do we reconcile that? How do we look at Alzheimer's if somebody wanted an advanced waiver of final consent because of Alzheimer's, and then when they reached a certain point in their dementia progression, wanted to have MAiD? That's a little bit tricky, especially if somebody is having what I would call, a pleasant dementia, if they seem to be enjoying their life and their time with their loved ones and their trips out and all that, but they can no longer remember any of their loved ones. They can't feed themselves, or maybe they can't even remember to speak. I don't think I feel really very good about saying, okay, I'm going to go and give that person a needle now and end their life, because the person that they were before they were that demented didn't want them to live like that. I've got some discomfort about that one. And I think in the end, as a practitioner, you have to be able to say, I'm not comfortable with this. I'm going to withdraw. Maybe you might meet the criteria, but I don't feel comfortable being the assessor or provider. And I always have that option as an assessor and a provider. People with personality disorders who want to use this as a wedge, say, well, I can kill myself if you don't give me what I want. See, so that can happen. And that could be a little bit of a tangly issue as well. Psychiatry involvement, we've been fortunate here in that our psychiatry group has agreed to get a group together for when MAiD, people who are requesting MAiD, have some underlying psychiatric issues that we need to weed through and determine, does their psychiatric illness impair their capacity to the point where we can no longer allow them the right to choose MAiD or not. And so sometimes we need a psychiatry opinion in that. And there has been a tendency sometimes for all kinds of practitioners, including psychiatry, to sort of go, I don't want to weigh in on that. I do ask somebody else. I don't want to be part of that. And in the end, we really do need people to weigh in on this. So we have a group that has agreed to weigh in on underlying mental illness in MAiD requests. We talked about some of the current ethical issues. There's still some places that refuse to allow MAiD on their premises. St. Pat's, Glenbrook, there's a new hospice going up in Central, which is going to be on Catholic ground, which they have said right off the bat, they're not going to allow MAiD there. So, should we allow that? Should we not? Should we force the issue? Should we just sort of deal with it as it comes up? I think one of the big issues I'm hoping we can resolve, and that you guys can help me resolve, is around the clinical practice guidelines for nursing and LPN, in saying that, you can't talk about it unless the patient brings it up. Now, I understand that was the medical legal advice and that the lawyers say that's the safest course of action so that nobody will think that you are counseling somebody to commit MAiD. But really, there's a professional duty to help somebody have informed consent. And like I said, if they don't know all their options, they can't really make an informed choice. So, but I can't tell, the College of Nurses what they can and cannot put in their clinical practice guidelines. That's outside of my purview completely. So it's really up to you guys to have that discussion and to come up with, how best to go forward in a way that serves your patients and your membership. Organ donation, we need to be able to do organ donation on MAiD patients, but currently they're not able to do that in this province, although they have done it in Nova Scotia and elsewhere. So I think it's just a matter of time before that becomes in the forefront here. And the current mental illness eligibility that's going to happen in less than 2 years now. So I think we're also, looking at setting up a review process, although we do a pretty good vetting, I think, of each case during and then afterwards to make sure we did it properly, that we got the form signed out all right, and that we really explored all the little cul-de-sacs along the way to make sure we're doing our best job for our patients and for our practitioners. And there really is quite a big supportive process here. I mean, 90% of these cases are very straightforward, but the 10% that are tangly can be real doozies. So I've learned that, as long as you're careful and you include all of the opinions and you get, you don't leave any stone unturned, we can go forward. Even in the tangliest of situations, we can do it professionally and fairly in a way that doesn't burn out the practitioners, but that also gives the patients their due course. So yeah, so anyway, that's us. That's my email address, aaron.mckim@easternhealth.ca. If any of you have any questions after the fact or want to know any information, feel free to send me an email. Yeah, so that's it. Thank you very much, and I'll take if there's any questions.
Thank you, Dr. McKim. This is Wanda Squires here. I'm not sure if Debbie, if you wanted to say a few words also.
Oh, I think I might have lost you there. Can you hear me, Wanda?
Yeah, I can hear you. Yeah, for sure.
Okay, so thank you, Dr. McKim. I guess I just wanted to, and I shared these slides with Wanda. You did receive them, did you, Wanda?
Yeah, I'm just trying to bring them up here.
Oh, are you?
Yeah, do you have them there? Can you see my screen?
I can.
Yep, we can see it.
Okay, perfect.
Thank you. So I just have a few slides, just some quick resources, and Dr. McKim included some of them in his as well. You're going to have to advance, I guess. Are you, Wanda?
Yep, yep.
There you go. Okay, the next one, please. So these are just some quick resources. So this is just to capture the MAiD update. So, and then the next slide. Yeah, so here's some timelines then of what MAiD was in 2016. So your build C14 and what it is as of March 17th, 2021. Now your build C7. Next slide. And here it is here in a snapshot. So you can certainly go to the Government of Canada's webpage, and they have it laid out nicely there. And Dr. McKim also had a slide with it on as well. So it'll talk to you about what MAiD was before in the legislation as 2016 and what the new law looks like today. And then as Dr. McKim mentioned, we will have another slide to add in 2023, no doubt. And then these are just some resources that I put together for you. Same information that Dr. McKim provided as well, but just a quick reference for you. So for whichever regional health authority you're with, just reach out at any point in time to your MAiD coordinators. Their emails are there, their phone numbers and faxes are there as well. Okay. Next slide. So these are the forms that we have, and I'm sure that the other regional health authority has them as well. So we have 7 forms as it stands right now. That looks at the patient request, then the primary practitioner form and the secondary practitioner form. And in those forms, they really reflect the legislation. And I know we started off saying that we've both been involved with palliative care before, and the legislation talks about palliative care and how important that it is to have that conversation with the patient so that they're aware of their palliative care options. And that's actually written in the legislation and is reflective in these forms as well. So the practitioners will have that conversation to ensure that these people have looked at palliative care options, if they didn't know about them, that they become aware of them, and give them time to consider, do they want to avail of some of them? And as Dr. McKim has said, sometimes they'll say yes, other times they'll say no. But informed consent is really important. Then we have a form called consent and capacity as well. And the primary can complete that form, or there's times that we do have to reach out to geriatric psychiatry to assist with that form, depending on the situation. We also developed a communication intake referral. And that's a form that the primary practitioner will complete, and then it goes to our MAiD coordinators in the community to ensure then that the community health nurses going to offer the palliative care resource.
Back over here. You coming in?
Okay,
yes, there's no worries.
Some background noise.
All right, sounds good.
Sorry, there's just some talking there. Okay, yeah, okay, sorry, Wanda. Can you just go back one slide? Thanks. Yeah, so the community referral, so that's just ensure that everything is together. But what I will, I guess, highlight for you there is that in that form, there's a place there where the physician will order the IVs, because with medical assistance in dying, it is necessary or a nurse practitioner order for the IVs for medical assistance in dying. And you'll see that referenced in the documents from both colleges, actually. I'll talk to you about that in a second. We do have then the IV protocol for the medication order set that the primary practitioner will complete and that be sent to the pharmacist. And we're only, in this province right now, we're only providing the IV route. Then there's also a MAR that is also completed by the primary practitioner as well the day of the procedure. So the MAR, I usually ask the nursing staff to have that on the chart for the primary practitioner that day, as well as the death certificate. And I'm not sure, Erin, if you had mentioned about completion of the death certificate or not.
Well, the death certificate, the direction that I got when I was with the Department of Health a couple of years ago, was that they basically didn't want to involve the coroner. They didn't want to give the coroner's office one more thing to do. So they said, don't put MAiD on the death certificate, which I'm not entirely sure I agree with. So now, apparently, I just saw the correspondence today, Debbie, thanks for sending that to me, that they're kind of looking at, should they put a tick box on the death certificate for MAiD or not. I don't think a tick box is really that useful. It just takes eventually you get so many tick boxes on the thing that it becomes, just totally messy. So I think that MAiD should actually be as the immediate cause of death. But currently the direction that the Department of Health has given us was not to put MAiD on the death certificate at all. So it's the underlying diagnosis is the cause of death. But I think really it should be, having thought about this for a few years now, I think really we should have medical assistance in dying as the immediate cause, and then the underlying medical condition as the underlying cause, the contributing cause from that as a result of, their cancer or their neuromuscular degenerative disorder. So I think that would actually be more truthful and closer to the mark. And I don't think that would necessarily burden the coroner's office at all. But it's different in every province. I mean, in Ontario, every case goes to the coroner. Every MAiD case goes to the coroner, and the coroner records it and puts out quarterly, statistical analyses on these, and sort of really takes ownership over it. Whereas here, the coroner isn't even aware of who's had MAiD and who hasn't. So it's interesting seeing how different this is in different provinces.
Absolutely. And another question that we'll often get too from the person themselves making the request or from families is regarding insurance as well.
Yeah, it doesn't affect insurance. I looked into that, right off the bat when it was first coming down the pipe to see if that was an implication, but it's not included. There are no insurances that are invalidated because of medical assistance in dying. In fact, it's interesting. Most insurances that have invalidated if somebody were to commit suicide, that is only in effect for the first 6 months. So most insurance policies, even if you did kill yourself, the insurance is still valid as long as it's been more than the 6-month window period. So you can't go and get insurance right away and then kill yourself and collect on the insurance. But if you had the insurance policy for a while and then you happen to kill yourself, most insurance policies are still valid. But medical assistance in dying has nothing to do with any of that and will not be considered a suicide under any circumstances.
Thank you. Next slide, Wanda, please. Thank you. So these are your practice standards. So as you can see there, so our partners or our co-workers in Allied Health, they also have documents to follow to support their practice, as well as we would have with the College of Licensed Practical Nurses of Newfoundland and Labrador and the College of Registered Nurses of Newfoundland and Labrador. So it's really important to take this opportunity, one, to reflect on any conscientious objection that you may have, and to kind of sort through yourself how you could be involved in medical assistance in dying, how you can, I guess, what part of nursing care you could provide there, whether it's assisting with drawing up the medication, or whether it's supporting the person and the family, being there that day if the person asks you to be in the room. It varies each and every time, and but those are areas in our practice as nurses that we couldn't certainly be a part of medical assistance in dying. And I'll refer you to the regulatory bodies documents on medical assistance in dying to look at those documents that will guide and support your practice there for sure. But it is an excellent opportunity today to reflect on your own thoughts on that for sure. Next slide, Wanda, please.
There's just a quick question there about could a parent of a child that has an underlying condition and is suffering apply for MAiD? And the answer is no. You can't actually consent to it by proxy, or next of kin can't do it. It has to be the person themselves, and they have to be eligible and meet all the criteria. And a child, unfortunately, under the age of 18 currently would not meet the criteria. Go ahead.
Thank you. Thank you. So these are some more added resources. Dr. McKim has referenced KMAP. That's an excellent resource, as well as Dying with Dignity Canada, also another good resource as well, but certainly CNA, CNPS. What you'll find with some areas right now is that you'll find that they'll have communication there to say that they are currently updating their files to represent the current law for Bill C7. So everything is not where it needs to be quite yet. And Eastern Health, when you go in through our internet, you'll find the same message as well, because we're currently updating our documents as well. And Wanda informed me too, just before the presentation, that they had theirs completed and theirs should go up hopefully tomorrow. So that's fabulous. So it's important though to refer to your governing body documents, absolutely. Next slide, please. So again, these are just quick reference, but I will say to you though that College of Nurses of Ontario, they do have their documents updated for 2021. So that's there already. And the next slide, please. Okay, and I reference Dying with Dignity and KMAP. Okay, the next one, please. And there's your references again within our province. NCNA and CNPS. And that's it for me, except for I will just mention a couple of things. So besides taking this opportunity to reflect on your own views for yourself and your loved ones with respect to medical assistance in dying, and then to expand that out further than you as a nurse, it's also important then that you do consider then self-care for yourself. Palliative care, it's a big part of what we do each and every day in providing nursing care. So self-care then is really important then when we also look then at medical assistance in dying, and important then that we learn to do informal debriefs with each other around the nursing station, or take it aside to another room to do an informal debrief in certain areas. I know in Eastern Health, and hopefully in the other regulatory bodies as well, they have some supports there that would help you with an informal debrief as well as then a formal debrief as well. That's really important to happen. And I think that might be it. So for Eastern Health, certainly as Dr. McKim has pointed out, the intranet is where you'd find our forms as well as our other resources and supports there. And I think that is it for me. Oh, the only other thing, sorry, is timely advise your manager, primary care provider, or the MAiD coordinators if the person is declining in their condition, if they change their mind or want a different date or change their mind completely, or if they're now requesting organ donation, such that the primary practitioner can go in and have that timely conversation then with the person. So that's really important that we know all of that in a timely manner. And that's it. Thank you. Thank you to everybody for being a part of Medical Assistance in Dying. And we're open certainly to any questions you might have.